Okay, good morning, everyone. Today we are going to talk about atrial fibrillation. So this topic and the topics related to arrhythmia is one of the richest topics ever, and they have a lot of detail that we cannot go through everything. We will try to see a brief view of the pathophysiology of the disease and the selection of drugs used to treat it. But if you would like to ask more about it, please make it after the lecture because it will take long. If every question comes to your mind, you will ask it. There are a lot of things. I will try to make it as much easy as I can. Also, I'm sick. I have a broken teeth. So any question you have later, you can send me. Then once I feel better, I will reply to the question. Today, we will take Afib. Tomorrow, we will make the endocrinology, diabetes, and hopefully hypo and hyperthyroidism. Okay, so this is our heart. And what happens in a normal heart, how our heart works. This is called sinoatrial node, SA node, and this is the pacemaker. This is the controller of the heart. So this SA node generates pulse that reach to the AV node here, atrioventricular node, and then these signals are transferred to AV bundles, or what is known as Purkinje fiber. This is like electricity generated here from the SA node, transferred here to the AV node, then distributed to the Purkinje fiber to send a message to the cardiac cells to contract. So this what happens in a normal patient, in a normal person. Based on this pulse generation and spread, we can see here from the electrocardiogram this like normal drawing, which means this is P wave. We have P, Q, R, S, T. P reflects the atrium pulse or the atrium signal. Then QRS comes like that. Then T comes here. This is how like the cycle of the heart happens, which we call action potential of the heart. This is how electricity or signal moves through the heart. This is Q, this is R up here, and this is S down here, then we have T there. This is why we take some medications like citalopram, for example. It causes QT prolongation. Q is here, T is here, so when the distance is prolonged here, it means that the signal of the heart is longer, which might lead to any kind of arrhythmia. There are many types of arrhythmia, and some of them are like, if some of them happen, it might lead to the other. So a patient might have more one than arrhythmia. We don't have to go deeply in that. And so this is why we say like fluoroquinolone, citalopram, some other medications will cause QT prolongation, which is the distance between here and there. Okay. What happens in atrial fibrillation? So again, the pulse generates here from the SA node. Okay, but rather than going directly to the AV node here, no, this is not happening. You see the signal will be moving first in the atrium, moving back and forth, moving here and there, then one of them will go to the AV nodes, which means what this will mean, when some impulses are generated, and rather than going directly to the AV node, it stays inside the atrium and going back and forth until one of them decide to go to the AV node to complete the contraction of the heart. It means that the atrium, due to the multiple signals, will start to contract more. This is why in atrial fibrillation, the number of pulses might reach to 200, 250. And this is impossible to happen if the signal goes in the normal way, which is SA node, AV node, Purkinje fiber. It's a long process that takes time. But because in the case of atrial fibrillation, the pulse or the signal is still in the atrium starts to contract more, to be faster, reaching to 200 and 250, because the distances that the signal has to go through now is shorter. Okay, and then one signal will reach to the AV bundle and go. This is why in case of atrial fibrillation, you will find that the atrium is contracting with no relation to the ventricle, like what normally happens, systolic and diastolic. No, the atrial is playing with itself and the ventricle is playing with itself. Okay, the rhythm that has to happen in normal situation is lost. So what will happen here? Because the atrium contractility or the atrium rhythm is lost, you will find that there is no P wave, which reflect the atrium rule in the cycle. So with atrial fibrillation, P wave on the echocardiogram will not be there. And also, you will find that a lot of irregularity has happened. Because what will happen? Look here, look to this shape here. When we come to define the atrial fibrillation, we said a kind of irregularity. Because you see, here is R and here is R. You see the distance? Let's say the distance here, just let's say it's 1 millimeter. In the second cycle, the distance between R and R is 0.5 milliliter. In the cycle after, it's like 0.75 milliliter. Of course, it's shorter than that. I'm just giving an example. So we call the atrial fibrillation a kind of irregularity of heartbeats, because like everything is lost now. Okay, so we can see here that the problem of arrhythmia normally is due to either the generation or the conduction of the signal or the generation of the signal itself. What is the meaning of generation of the signal? So this small part here, the SA node, is the controller of the heart. Why? Because it has the highest automaticity. It can generate pulse. However, and due to many conditions, some other parts, like on Purkinje fiber here, might take the upper hand and start to give signals. So you can imagine now the heart has two generators. One is SA node and the other one is some point here on Purkinje fiber. So this gives signals, this also gives signals, so the heart will pump irregularly, and a lot of issues will happen. When another point other than the SA node start to give to generate pulses, we call it ectopic focus. And in other cases, more than one point can generate pulses, and we call it ectopic foci, more than one. You don't have to worry about that. You don't have to remember that. You don't need it, just to understand how the thing happens of arrhythmia and why like the regular heartbeat is lost and the heart started to move irregularly, okay? So this is what happens. For a doctor, for a physician, for a clinician to treat arrhythmia, what he needs to do, he needs either to give something to regulate the generation of pulses, like if the person has more than ectopic focus, or to give something to regulate the spread of the pulses rather than going here and there and there, then going to the AV bundle, we needed to go directly here. Generally speaking, if a patient has ectopic focus or ectopic foci more than one, the best option is to make ablation. Ablation means burning to the ectopic focus. The doctor used laser or catheter and make ablation, enter through the vena cava and reach to the focus. Let's say it's here and burn it. So stop it, it will stop working and the rhythm will be back to the control by SA node. Otherwise, the doctor will give something to control the electricity generation in the heart. Okay, so this is generally how arrhythmia happens. Regarding atrial fibrillation itself, it's considered one of the supraventricular tachycardia. Supraventricular because this is the ventricle and it's happening above the ventricle, so it's supra. Which point, ma'am, you need me to repeat?
In which one the ablation is the drug the best choice, in flutter or so multiple foci or one focus?
Okay, so we have atrial fibrillation and atrial flutter. In atrial flutter, ablation is preferred generally. Okay.
So flutter is only one focus, not multiple foci. That's right?
It might happen to one or more. I told you you don't have to go in details in that topic.
Okay.
Okay. But in atrial flutter, it's preferred. The ablation is a first choice. In atrial flutter. In atrial fibrillation, it's up to the doctor if the patient is not responding to medications. Okay? Okay. So.
Okay, thank you.
Atrial fibrillation is a kind of supraventricular tachycardia, which we can define it as irregular heartbeats, because as we see on the ECG, the P wave is lost and the distance between R is changing with each cycle. And also the coordination between the atrium and the ventricle is lost. This is why the rate might reach to 200, 250, and even more, because the atrium is contracting without any control. Okay, so if we come to classify the atrial fibrillation, we have paroxysmal. Paroxysmal one is a recurrent self-limiting episode. Like it happens a lot, and it like the rhythm is controlled automatically there without our intervention in some cases. And one episode will resolve in less than 7 days. One episode will resolve in less than 7 days. This is a paroxysmal. But however, if someone is diagnosed with paroxysmal atrial fibrillation, I cannot depend on the automatic resolution saying, you know what, it resolved by itself, so I will leave him and it will be resolved. No, because this is not what will happen every time. Yeah, it might happen automatically once, but the next time it might not happen, and so the control will be lost, and so a chance of blood clot will happen and the patient will die. So we have to intervene anyway. The next type is persistent, and this one is a kind of continuous. A patient might have one atrial fibrillation episode, and it might last from more than 1 week to less than a year. Okay? And in that case, in the kind of persistence, The sinus rhythm might be lost and we need to restore it. How we restore it? By medication or cardioversion. Cardioversion is a kind of electrode that the doctor connects to the patient body, and through the electricity, the stimulation to the SA node is done, and so the control of the heart is restored to the SA node. This is cardioversion. Or if medication can achieve it, okay, we can use the medication, but either or can be used, cardioversion or medication in case of persistent. We have long-standing persistent, which is like last more than 12 months, and we still need to restore the sinus rhythm. Okay, the permanent one, it lasts more than a year, okay? And in this case, the sinus rhythm is no longer achievable or desirable. And another point on the fiber, as we mentioned earlier, took the control of generating the impulses, and this is how the heart will be working. Like the generator will be different, not the normal SA node, and we will keep it as is. Okay. Regarding this slide, what is the difference between Afib and atrial flutter? What is atrial flutter? Atrial flutter is still considered one of the arrhythmic disease or abnormal heart rhythm, but in case of atrial flutter, it occurs when a short circuit in the heart causes the upper chambers, which is the atria, to pump very rapidly. Okay, so if we get back here, let me show what I mean. In this case, we said that the sinoatrial node, the SA node, start to generate impulses, and rather than going down here to the AV node, it start to play around the atrium for some time, then one of them will go to the AV node. But what happened in atrial flutter is the signal comes here, okay, and reach to the AV node. What should happen in normal case? Okay, Noha, yes. Okay, so Noha Al-Kholi, can you open your mic, please?
Yes, I'm here.
So what happens in normal case when a signal is generated from the SA node? Where does it go?
It goes to AV node.
Which is here, yes?
Yes. After that, it gives a sign for the ventricular to contract, so depolarization of the ventricular. After that, in a normal case, it will, after depolarization, so repolarization, which is filling of a ventricular.
Yeah. So regarding the signal itself, it moves from the SA node to the AV node, then to the Purkinje fibers, correct?
Yes, yes.
And what happens in atrial fibrillation?
In atrial fibrillation, the sign from an AV node to an SA node will be deleted. So, or will be very long. So it will be too much signs before an AV node. So it will be irregular heartbeats.
Yeah, like briefly, the SA node will generate one impulse, and rather than going directly to the AV node, it will keep playing around here.
Yes.
And this is why atrium will start to contract more than ventricle, and the coordination is lost. Okay.
Yes.
In atrial flutter, what happens is that the signal here start to move in a circular movement like that, rather than going to the AV bundle and transfer down to the ventricle. No, it come, hit the AV node, playback, the same signal. This is why in case of atrial flutter, the atrium started to play like, without any control, worse than the atrial fibrillation. The atrium start playing with no control. This is why the ablation is the best solution, because I need to go, stop. Okay, and then another generator will be created around the fibers here. This is why it's easier in case of flutter to make ablation rather than giving medication. The signal is moving in circle, stimulating atrium, and then the ventricle is left. Maybe one signal will reach, maybe it takes time, so a bigger chance for blood clot. So this is why we have to stop that by making ablation. Okay. What are our goals of therapy? On the short-term run, if it's not like the chronic permanent, we need to restore the sinus rhythm. We said that in case of permanent, we don't care about restoring sinus rhythm. The long-term goal is to prevent arrhythmia recurrence, because the patient who develops arrhythmia has a higher chance of redeveloping arrhythmia and again and different types of arrhythmia. Okay. In the long term, or in all term, to reduce the risk of thromboembolic events. Okay, so this is another important point. Sarah Callow, are you there? Can you open your mic? I need to ask a question here, please.
Yes.
Hi, good morning. How are you?
Hi, thank you. Good.
So, why the patient who has atrial fibrillation will have a high risk of thromboembolic events?
Because of the abnormal sinus rhythm.
Yeah.
So, like, patient would be more disposed to clots.
Yeah, like how it happens, in your opinion, why do you think there is a chance of blood clotting in case of atrial fibrillation?
I think because also there would be reduced perfusion to the arteries. This also causes stroke, like when there is less blood coming, going in circulation because of the irregular heartbeat.
Yeah, so if we come to look back here again to the heart, in this case, when the atrium is receiving like multiple signals, do you think that it will be able to contract fully? Like when
No.
contracting quickly, will it be able to contract fully?
No.
Which means that there will be a residual amount of blood in the atrium, correct? Mm-hmm. This residue of blood with time will aggregate and make a blood clot. Then it will be transferred to the ventricle. Then the ventricle will pump the blood with the clot, and it might reach to the brain and make stroke. So it's due to like the stagnant blood in the atrium. It will have a bigger chance of developing a blood clot that will be transferred from atrium to ventricle. Then it can be pumped around until reaching the brain and cause a stroke. Okay, thank you. Okay. So, okay, what are the triggers of atrial fibrillation? Alcohol is one, caffeine because it's a stimulant. Stimulant means higher heart rate, tachycardia. Exercise, let's say over-exercise, not exercise only. Hyperthyroidism due to the stimulation, again, of the heart. And generally, there are no consistent triggers. Sometimes with age, sometimes regarding the over-exercise, it's very common in football players that they develop a kind of arrhythmia due to the over-exercise, the overstimulation of the heart. Okay. Anyone here watch football? There is a player who developed this thing before like 1 month. Anyone here is watching football or no? Okay. He was a Danish from Denmark player called Ejection, and they have to put a defibrillator in his heart to keep controlling the rhythm there. Anyway, so this is the action potential of the heart. We don't need to go deeply in that, and this is where each class of antiarrhythmic will work. Don't overthink about it because quinidine and lidocaine, for example, we will not mention it here in atrial fibrillation. So anyway. Okay. Now, with regard to a patient who is diagnosed with atrial fibrillation, what is my main goal? To control the heart rate or the rhythm control?
There is no preference. It's according to the patient choice.
Choice?
I think so. No preference between the rate and the rhythm. But if there is some criteria to go to the rate control, like if there is it's not the first time, if he more than 65 years, but I mean if I have the criteria to use the rate control and the patient asked me, no, I want to fix the problem from the beginning, so I can use the rate rhythm. Am I right or not?
I think you just mix it down. So if the patient has like
okay. Sorry, sir.
Multiple recurrence, this is what you meant, Noha, correct?
Yes, if it's multiple recurrence, so I'm gonna go with rate control more.
No, ma'am.
If it's okay.
I will consider rhythm control in this case. If the patient has multiple recurrence, if the patient is highly symptomatic, if the patient has extreme impairment in quality of life, at that point, I will consider rhythm control. But generally, I need to control the rate. So the cornerstone is controlling the rate. Do you know why? Because if you don't control the rate, what will happen after atrial fibrillation? If the rate is not controlled, the contractility will not be controlled and the patient might develop congestive heart failure. The patient might develop a stroke. So I need to control the rate. Then there are some cases when or where I will consider the rhythm control in addition to the rate control. Regarding the other point you are saying about the patient select, generally speaking, we have the ethics of autonomy. The patient has the right, like, for example, if the patient refuses the treatment, I cannot force him. You know what I mean? If the patient with any disease, if the patient refuses the treatment, it is the patient choice. I have to keep the autonomy. But generally speaking, with each disease, I'm not going to ask the patient, which medication you prefer? He might doesn't know what is that or what is this. Okay?
Okay.
So where we are. Okay. So I need to discuss this slide later. I hope we can find another slide first, then we can go through that to take it step by step. Okay. Okay. Regardless of this slide for now, what usually happens generally in atrial fibrillation patients? Okay. So I need first to control the rate, okay? And I give something to control the rate, something like beta blocker or calcium channel blocker, verapamil or diltiazem, depending on the patient. However, if the patient has some criteria, I have to consider rhythm control in addition to the rate control. Okay, these criteria are, first, if the patient is highly symptomatic, or if the patient has multiple recurrence, or if the atrial fibrillation has extreme burden or extreme impairment of the quality of life of patient, or if the patient has arrhythmia-induced cardiomyopathy, like the cells of the heart itself started to get affected due to arrhythmia. In that case, I will have to consider rhythm control. Okay, so let's go with the first case where the patient doesn't have the criteria. So I started only with rate control using beta blocker or calcium channel blocker. If the symptoms resolve, that's fine. I will continue on the beta blocker or the calcium channel blocker and follow up with the patient. But if the symptoms don't resolve, in case of the patient who doesn't have any criteria, at that point, I will also consider the rhythm control because rate control alone was not enough. Okay, so I will add something to control the rhythm. Okay, is this point clear until now? Okay, now we are at which point? At the point of using something for rhythm control and something for rate control. Okay. If the patient has paroxysmal atrial fibrillation, which is the one that resolves in less than 7 days, it means that it might be a low burden recurrence, like it doesn't occur frequently. At that point, I don't have to ask the patient to keep taking the antiarrhythmic on a daily basis. On the other hand, I tell him to keep this pill with you. They call it pill in the pocket, just to put the pill in the pocket. If you start feeling the irregularity of heartbeats, just take it. This is in case of the patient with low burden recurrence. It's not a repetitive recurrence. So they call it pill in the pocket antiarrhythmic therapy. Maybe sotalol, maybe amiodarone, depending on the doctor's choice. Okay, we are still at the paroxysmal level. Okay, keep the flecainide and the propafenone for now, Noha, because we cannot use them alone. We have to add them to one of the calcium channel blockers. So what if it's a high burden recurrence, like it happens again and again? At that point, I cannot tell the patient to keep your pill in the pocket because it might happen once or twice daily. At that point, it's like logic to tell him keep the pill in your pocket and once you feel it, take it. Rather, it's preferable to put him on a maintenance therapy, like you will be taking sotalol every day, and that's it. This is if it's a high burden recurrence. Okay, what if In case of high burden recurrence, the maintenance antiarrhythmic therapy was not enough. It wasn't controlling. Although the patient is taking amiodarone or sotalol on a daily basis, his rhythm is still not controlled. At that point, the best option is to make ablation. Ablation is burning to the ectopic focus in the heart. But we don't go there until it's uncontrolled with medication. Okay. If it's a persistent atrial fibrillation, we are still now at the stage of taking both antiarrhythmic, something for rhythm, and something for heart rate. If it's a persistent atrial fibrillation, which we say between 1 week to 1 year, the first thing we might think of is cardioversion. And we already talked about cardioversion, which is connecting electrode with electricity to the patient body, and through the electric currents, we restore the normal heart function and restoring the generation of impulse to the sinus, the sinoatrial node. Okay, after the cardioversion, if the symptoms improve, like the patient is okay, but atrial fibrillation gets back, at that point, I need to put him on a maintenance therapy of antiarrhythmic. That's logic. I made cardioversion, the symptoms improve, but the patient has a recurrent again. I'm not going to keep doing cardioversion every time. I will, because like the normal electricity in the heart is restored now under cardioversion. However, the patient starts again to show atrial fibrillation symptoms. At that point, I will put him on maintenance therapy of antiarrhythmic. Okay. If after cardioversion, the symptoms improve and the sinus rhythm is maintained and everything is okay, I will just keep an eye on the patient and observe him. If something happens, I will put him on the maintenance therapy of antiarrhythmic. Is this point clear until now or not? Does anyone have a question, direct question about what I just said? People, are you still alive there?
Yeah, doctor, like what's the rate of recurrence for Afib? Like how bad does it go? Is it easily controlled or it's like a progressive thing? You know, like dementia, it's always gonna be progressive. There's no cure. So do you expect like someone not to develop like recurrent or like go more away from paroxysmal?
I'm sorry, I didn't get your question.
Like what's the rate of recurrence? Like, is it a progressive disease?
If you keep it under control, it depends on like, did the patient develop any blood coagulation or not? Anyway, if the question is about recurrence, yeah, it's a highly recurrent disease. Up to 50% of patients will have a recurrent episodes of atrial fibrillation. If this is your question.
That's what I meant. Yeah, exactly. This is my point. Yes. Yeah.
Okay. Yeah, there is a very high recurrence of atrial fibrillation. Okay.
Thanks.
Okay. Now we were talking about a normal patient who doesn't have like heart failure, doesn't have angina, doesn't have myocardial infarction. Okay. Again, people, anyone has any question about the simple algorithm we discussed for a patient who only has atrial fibrillation? Okay. So now, what if the patient has, okay, someone sent something. Thanks. Congestive heart failure. Like a patient has heart failure and atrial fibrillation. And it's common to have both, because when the electricity generation and the conduction is is not controlled in the heart, the contractility also is not controlled, and there is a bigger chance of developing congestive heart failure in the heart. Just to think about it, arrhythmia, including atrial fibrillation, is the software of the heart, the electricity, the generation, the impulse. Congestive heart failure is the hardware of the heart, the cells itself, the contraction, the power of contraction. Anyway, if a patient has congestive heart failure, what will I do in that case? I will look to the ejection fraction. This is the main criterion I look at. If the left ventricular ejection fraction is 40% or more, my preference right away is amiodarone. Okay, amiodarone if the left ventricular ejection fraction is 40 or less, which is left ventricular congestive heart failure with reduced ejection fraction. Okay, amiodarone has a lot of side effects. This is why I have to keep an eye on many things. Amiodarone increases the photosensitivity. So if someone is on amiodarone, please avoid direct exposure to sun. Use a high SPF sunscreen. Amiodarone might cause thyroid dysfunction, so the patient has to have a regular blood test for thyroid. Amiodarone might cause hepatic toxicity. This is why I do the liver function test, and if the AST is doubled, I have to stop the amiodarone at that point. Also, amiodarone might cause pulmonary toxicity. This is why amiodarone is one of the unfavorable medication on the level of side effect, but at some point it might be the only choice to use. But if a patient is taking it, I have to remind him with these many side effects. Okay, let's say that a patient who has a left ventricular ejection fraction of 32, okay? Who was asking the last question about the recurrence rate of atrial fibrillation? And who was asking the last question? Like the recurrence rate of atrial fibrillation. Okay, he disappeared. Anyone else like Ahmed Tanzawi, can you open your mic, please?
Yes, Dr. Rahim.
Yeah. So let's say that a patient with ejection fraction of 32, and he has like atrial fibrillation, and you give him amiodarone. Okay. You have three choices in that case. The patient is stable on amiodarone and the side effects are under control. At this point, I will keep on taking amiodarone, correct?
Yes.
Okay. What if the patient didn't respond to amiodarone? Also taking amiodarone, we couldn't restore the rhythm control. What will we do?
We'll go for ablation.
Exactly. What also if the patient AST level is like threefold? What will you do?
ST level, I didn't get you, doctor. If still what?
His AST, which is like the liver enzyme, because it's hepatotoxic. Amiodarone is hepatotoxic. What if the AST level is more than twofold?
We have to stop the amiodarone.
Exactly, because I cannot keep using it anymore. But do I have any choice, any other medications that I can use in that case?
Can I try the sotalol?
No, if the ejection fraction is less than 40, I cannot. It's only amiodarone. So if the AST is doubled and I have to stop amiodarone, what else I can do?
We'll go for cardioversion.
just to keep that in mind, cardioversion is a temporary solution. Okay, and it will not work on that case. So why not to make ablation again? What's wrong with ablation?
So we repeat the ablation.
We do the ablation because the mite doesn't have ablation before anyway. He tried amiodarone, he was responding very well to the amiodarone, but the side effect of the increased AST is intolerable anymore. I cannot take amiodarone anymore, and I have no other choice. So make ablation.
Okay.
Okay. Does anyone know what catheter ablation means? Like, what do you mean? What do we mean by ablation? In that case, it's not like ectopic focus. It's still the SA node that send signals, but these signals are like mini signals, uncontrolled signals. So in that case, what kind of ablation we do? Or what happens in that ablation?
It is a catheter ablation.
Yeah, what happens in that? Like what does it do to the heart?
The meaning of the ablation, which I understand, it is destroying the area. That is happened in it in multiple foci or atrial flutter. What happened is a catheter or more inserted into the blood vessels, and in this case, threaded into the heart using fluoroscope technique or X-ray picture. And once it is reached, the location of the abnormal heart tissue has been identified using the diagnostic catheter. The special ablation catheter will be positioned in this way and called heart burning to destroy these abnormal foci. That's what I am understanding.
Yeah, but my question is, if it's only one thing, like the sinoatrial node is giving the signal, but the patient still has atrial fibrillation. So let's look here. So in a case if I don't have many like ectopic foci, it's only the SA node, but it gives many signals. Like the signal go here, then go there, then go here, then go there. This is what's causing atrial fibrillation. And I cannot use amiodarone to control the thing. I have to make ablation. So this kind of ablation is like creating a road for the signal in your heart. Meaning, like they use something using heat or cold energy, depending on the situation. And the doctor started to create tiny scars, like a scar here in that area here. So the signal has no choice to go anywhere other than going through this tiny scar until reaching the AV node. Okay? By this way, I guarantee that the signal will not play around because it already has a road. You know, when you open like a small road for the water to go through, it is the same for the signal. They make like tiny scar in the heart tissue to force the signal to go in a specific way rather than going here and there and here and there. No, you have a tiny scar here or here, depending on the doctor. Anyway, it's just an example for the signal to go slowly until reaching the AV node and then being transferred to the Purkinje fiber. Is it clear about the meaning of ablation if it's not ectopic focus or ectopic foci?
Yes. Okay. Yeah. Thank you.
So we have two types. One type is you burn the ectopic focus or ectopic foci if I have something controlling the heart other than the SA node. I go with something with leather, for example, or something else and burn it. So this one still has the upper hand. So the issue in that case wasn't that the signal was like erratic signal going here and there. No, the signal was normal, but there are other generators that was disturbing the heart rhythm. So I burn them. But what if there is no ectopic focus or any ectopic foci? It's just the SA node, but the SA node generate like erratic pulses or erratic signals, causing atrial fibrillation. One of the solutions, if I cannot control it by medication, is to make tiny scar in the heart tissue to make the signal go through a specific route, specific way, and this is how I can restore the normal rhythm of heart. Okay, people? Okay. I will say okay instead of you.
Doctor, please, I don't ask because time of the, but I don't understand what is the cardioversion in a brief note.
Okay, is this your phone?
Sorry for that. Yeah.
Okay. Noha, yes, it was before like 35, now it's 40. Yes, there was like one algorithm saying that 35, now they are saying 40. So let's say this is like the new algorithm or the new way of treatment. Okay. So Armia, you were asking about cardioversion. Okay. So
Yes, sir, please.
yeah, in atrial fibrillation disease, in atrial fibrillation patients, the electricity or the impulse is not controlled, correct?
Yes, sir. Yeah.
Okay, so I need to restore everything to normal. I need to restore the sinoatrial node to generate the sinus rhythm, and everything is getting under control. Okay, so I need to return that to normal, the abnormal heart rate or the abnormal rhythm to the normal one. Okay, the doctor will use a kind of electric, what they can call it, something like to transfer electricity to the heart, like something they put on the heart in a specific machine, and like electrodes they put on the heart, and they put one on another type on another part of the body. So I have a circle of electricity going through the body, going through the heart. This one is a kind of thing, you expose the heart to a specific cardiac currents. By doing that, you stimulate the heart to return everything to its normal. You stimulate the sinoatrial nodes to get back to its work. How this happen and the details about that, it's not our job at all. It's like the job of the cardiologist, but it's briefly like electrical thing, electrical, we can, what we call, trying to remember the term.
Okay, sir, thank you.
Like electrode, yeah. So we bought electrodes, they bought like electrode on your heart, and through a specific machine, a kind of electric shock are delivered to your chest from outside, but it will be transferred to your heart. And by this way, they keep giving shocks, and your heart rhythm is monitored through a screen. And by giving this electric shock with a specific power or specific voltage, at certain point, the sinoatrial node will restore its normal function. It doesn't work with everyone. They try it on some people and it doesn't work, but they try it with others and it does work. Okay, so it's simply electrode attached to your body, your chest, and transfer electrical shock to your heart with a specific voltage, a specific power, and there is a screen to reflect your heart rhythm. And until we reach to the normal rhythm, they will stop. And this is cardioversion. Okay. And however, cardioversion is not a final treatment. Like, although everything is restored, the recurrence rate of atrial fibrillation after is high. This is why after cardioversion, most patients will be put on medication to control arrhythmia, amiodarone, sotalol, or whatever.
Thank you, sir.
My pleasure. Yeah. Yes. Yes, Miss RX course, there are two types of cardioversion. Yeah, the one by electrical shock by electrode, and the other thing is to restore the sinus rhythm by medication. Okay. Where we are. Yes, amiodarone in the left ventricular ejection fraction less than 40. Okay. If the ejection fraction is more than 40, at that point I can use either amiodarone or sutalol, either or. Okay, the question again, what if amiodarone didn't work? I will go again to ablation. If sutalol doesn't work, I will go to ablation. Okay? Okay.
Doctor, I have a question.
Okay.
Does the ablation consider as a treatment or just to use it to control the symptoms or decrease the symptoms?
What do you mean? Like, I didn't get the question exactly.
So I mean, for the patient who use ablation, it's only to control his symptoms, but he will not. It's not a treatment.
No, it's a treatment. Now you make the electricity signal of the SA node go in a specific way. Okay? And you cannot use amiodarone for this patient, for example, if his ejection fraction is less than 40. You have no choice. Like, what else you will do? What else you would like to do in that case? Hello?
Okay. I read it's not a treatment. That's why I want to confirm.
Yeah, okay, I will tell you what they mean by that. You remember when we were saying that arrhythmia doesn't come for a patient as a specific type, like we are talking about now the arrhythmia for a patient who has a left ventricular ejection fraction of less than 40, we took 32 as an example, correct? And we used amiodarone and it didn't work for the patient, or he developed a high level of AST. At that case, I will use ablation, correct?
Yes.
Okay. However, making the ablation, because of the high recurrence rate, which is up to 50% of the patient, there might be a chance for the patient to develop a problem again, the same problem or a related problem. So what they will try to do in that case, they will try first to control the congestive heart failure, okay? And once we reach the 40%, at that point, we open other choices for ourselves to give the patient sutalol, for example. So it's not like I will make the ablation today and I will give him something. No, I will control the related disease like congestive heart failure in that case, for example. And once I can achieve a good improvement in the congestive heart failure, at that point, I can use something other than the amiodarone that I can't use anymore. So I can add sutalol to the patient just to keep it under control. But if you make ablation alone, yes, it will treat for some time, but even with any other medication or any other procedure, in case of atrial fibrillation or arrhythmia, the recurrence rate is still high. So I still need to prevent that.
Okay.
So it's a treatment? Yes, it's a treatment. But is it a permanent treatment? No, it's not a permanent treatment because there is no permanent treatment for arrhythmia.
Yeah, okay.
Is it
now
like clear now?
Yeah, very clear.
Yeah.
Thank you.
I know it's so complicated, like the arrhythmia and these things are so complicated, like I know, but we have to take what we can from it. Anyway, now if the patient has coronary artery disease, like the patient has angina, has myocardial infarction, or whatever. So in that case, the choices are more, like I can use things more than the heart failure. I can use the dronedarone, I can use the sotalol, I can use the amiodarone. Okay. If the patient is normal, no heart failure, no coronary artery disease, just atrial fibrillation, I can use anything. But I need to keep in mind 2 points here. For flecainide and the propafenone, we never use them alone. Like you cannot give a patient flecainide and that's it. No, you have to combine it with something that causes AV nodal blocking, something like verapamil and or diltiazem. Anyway, we are giving a patient something to make rhythm control, correct? But I have to put him on something else to make rate control already. So if I'm going to use propafenone or flecainide, the patient shouldn't be taking atenolol, beta blocker. No, he should be on verapamil or diltiazem, and at that point, I can achieve rhythm control with flecainide or propafenone. This is regarding to these two medications, and it's very important. Flecainide and propafenone has to be combined with calcium channel blocker, verapamil or diltiazem. What else here? Avoid use of flecainide and propafenone in patient with structural heart disease. Okay, if a patient like has structural heart disease, we already said that we give dronedarone. Like if the patient has myocardial infarction or anything, propafenone and the flecainide is not a choice anyway. Okay, now we talk about a normal atrial fibrillation patient who has nothing, and we already go through the algorithm. We said that we start by rate control, then if rate control is okay, that's totally fine. I keep on the medication. If the patient has certain criteria like multiple recurrence or cardiomyopathy due to arrhythmia, or it's affecting his quality of life, I have to consider rhythm control at that point. And we discussed that, like through the paroxysmal, what we will do, through the persistent, what we will do. Okay, now we talk about rate control and rhythm control. Still the most important part. I need to prevent blood clotting. So I have to give the patient something to prevent that. I need to know to see how this is go. I don't need that. No. Okay. So I have like many skills. One of them called before CHADS. There is another score called the has bled. And the has bled score is a score that assesses patients' bleed risk and the safety of anticoagulant use in atrial fibrillation. Has, H-A-S, bled, B-L-E-D. Each letter reflects something. So each one letter give a point. H for hypertension, give a point. A, if there is abnormal liver function, it gives a point. Also abnormal kidney function gives a point. S for stroke. If the patient has prior stroke or prior bleeding, it gives a point. A also includes age. If the patient is over 65 years, it gives a point. If the patient is like drinking much alcohol or taking drugs like prednisone, like NSAIDs that might increase bleeding, it gives him a point. Okay, and the has bled score, if the patient score between 0 and 2, it means that the patient has a low risk of bleed. But if it's 3 or more, there is a high risk of bleed in that atrial fibrillation patient. Okay, so the one we need here is CHADS 2 risk score. And this risk score, determine which medication, which stroke prevention medication I need to use in a patient. Okay, C, congestive heart failure, H, hypertension, A, age as more than 75, D, diabetes, S, prior stroke or transient ischemic attack. There is another score called Shad's Vasc score, and it adds to this criteria, these three criteria. If the patient is female, or regarding the age, it says that has blood. Okay. It said that if the patient is more than 65, like between 65 to 47, the patient will take 1 point. If the patient over 75, he will take 2 points. Or a patient is diagnosed with vascular disease. Anyway, I will need this score in deciding what I'm going to give to prevent the blood clotting, the blood clot formation. So a patient with atrial fibrillation, I have to put him on something to prevent blood coagulation. First thing, I look to the age. If the patient age is 65 or more, I will give him oral anticoagulant. So before looking to anything, if the patient is 65 or more, I will give him oral anticoagulant. He has something, he doesn't have, he has hypertension, diabetes, he doesn't have, whatever, the age is what I look to first. 65 or more, give oral anticoagulant. And when we say oral anticoagulant, we mean the new oral anticoagulant, which is the rivaroxaban, the apixaban, the edoxaban, the dabigatran, or the warfarin. Okay? This is if the patient is 65 or more. Okay, if the patient is less than 65 and has one of the risks mentioned here in the SHADS 2 score, like if the patient has prior stroke or transient ischemic attack, if the patient has hypertension, has diabetes, any of this risk score, if the answer is yes, I will give him oral anticoagulant. If the answer is no, I will look to the third stage, which is if the patient has coronary artery disease or peripheral artery disease. If the patient has peripheral or coronary artery disease, I have to look here. But if the patient doesn't have, like a patient is 46 years, like 46, yeah, and doesn't have anything of the CHADS score, I will not give him anything. I don't need to give him antithrombotic because he is still healthy, his heart is still healthy. Okay. If the patient has coronary artery disease and I have to give him something to prevent the blood coagulation, it depends on the patient state. If the patient has acute coronary syndrome without PCI, and Shamsi, we're asking me a question regarding that. I remember it, I will answer it after finishing here. So if the patient has ACS, something like angina, STEMI, non-STEMI, whatever, I will give him oral anticoagulant plus clopidogrel from 1 month to 1 year, depending on the doctor selection and the risk factors and a lot of factors to be considered here. Okay. If the patient has, this is one option. Okay. If the patient has acute coronary syndrome and the PCI, at that point, I need to add something else. I can give him oral anticoagulants plus aspirin plus clopidogrel, and the duration between 1 day to 1 month. No one give it for 1 day. Usually it's for 1 month. And this is how they deal with it. Okay. So Shamsi, we're asking, how can a patient have PCI without ACS, correct? Are you still there? I think you are sleeping. This is why you don't want to share with your voice.
No, I'm not. I'm here. I'm sorry. The printer is making sounds.
What PCI, Shams? What is the meaning of PCI?
Is it pulmonary cardiac angiography? It's
No, no,
it's
no,
like
no, no, no.
no. Okay.
PCI is a percutaneous
Cutaneous. Oh.
coronary intervention.
Mm.
Okay, it's a kind of surgery or whatever that's or a technique they use to treat the obstructive coronary artery disease. Okay, however, it might be used in other things other than the acute coronary syndrome. Like, let's say a patient has congestive heart failure. Okay, is there a chance with a congestive heart failure that the amount of blood in the coronary artery to be low or not? Shams.
Yes. Sorry.
If a patient has a congestive heart failure, severe congestive heart failure, okay,
Yes.
but he doesn't have angina yet, is there a chance in this patient that the amount of blood in the coronary artery is less or not? There is a chance or there is no chance?
There is a chance, 100%.
Can I diagnose this patient with ACS in this case or not?
No.
He is not yet, correct?
Yes.
However, I still can use the PCI, the percutaneous coronary intervention, just to facilitate the blood supply to the coronary artery. So this is the answer of your question.
Okay.
PCI can be used in something other than ACS, and the answer is yes. Okay?
Okay. Thank you so much.
My pleasure. Okay. Regarding this slide, to be honest with you, I would prefer that you check it on CTC because CTC will give you more details about it rather than the slide here. I mean, CTC will make it more clear, although it might be more details, but it will be more clear for everyone. Okay, people? We need to look to it at CTC. Okay, in CTC you will find that they are giving you like more details about the selection. You will find, for example, that he divides a patient to patient with atrial fibrillation and recent elective PCI. Elective means non-urgent. Okay, so a patient, for example, has myocardial infarction and did elective PCI. At that point, if the patient age is less than 65 and the SHADS2 score is 0, this is considered a low risk. The chapter is supraventricular tachycardia. When we come to the part of atrial fibrillation. Anyway, again, if the patient has atrial fibrillation and has recent elective PCI, at that point, I look to the age. If the age is less than 65 and the patient SHADS score is 0, I will give the patient only aspirin plus clopidogrel for 12 months. You know what? I will do a nice way to remember that. 1, 2, 3, 4, 5, 6. I have 6 cases, or I have six possibilities. So we can take one person for each possibility, and this is how you can remember it. Let's take one by one, okay? You will know what I mean right now. Samar Kassab, can you open the mic, please, if you can? Samar, are you there? Okay. Abdu, are you there, Abdu? Is Abdu there? Okay, Abdu is not there. Ahmed Tantawi, are you there?
Yes, I'm here.
Okay. Do you have any question until now? Or I can proceed to the use of anticoagulant or antiplatelet in case of coronary artery disease? No worries, Summer, that's fine. I understand.
So far, okay.
Okay, so far,
Maybe you
okay.
have to repeat it. Yeah, so far, okay. Yeah.
Okay. Okay. So now, Ahmed, we need to cover the last point in Afib, which is important, but it might be confusing because it has many possibility. So I will try to name each option under one of our colleague name. So this is how we can remember it later. Okay, Ahmed, you know what I mean? Like, I mean, I'm now talking about atrial fibrillation patient who has coronary artery disease. Okay, you will be the case number 1, which is a patient who has atrial fibrillation and has recent elective PCI, but his age is less than 65 and his CHADS score is 0. You don't have any congestive heart failure, any diabetes, any hypertension, like the simplest case. Okay?
Yeah.
So people, Ahmed, hopefully not, just an example, is atrial fibrillation patient and he has coronary artery disease with recent PCI, but he has CHADS score of 0, no congestive heart failure, no hypertension, no diabetes, nothing. Okay? And his age, of course, is less than 65. Ahmed is 40 years old, let's say. And in that case, I need to prevent the blood coagulation. What I'm going to give him?
Now, as long he's less than 65, so I think oral anticoagulant is not recommended. We go for the other. Yeah. And if he has a coronary, so I think we go for antiplatelet.
Yes. So I will give you over tablet to make it easier. Yes, ma'am, do whatever you think. Yes, Shams, you can do whatever you think. I will complete my conversation with Ahmed and you do whatever you like. So Ahmed, yes, you don't need oral anticoagulant, you need antiplatelet therapy, okay?
Okay.
Your antiplatelet therapy will be what? Clopidogrel plus aspirin for 1 year, okay?
Okay.
After 1 year, I will ask you to use aspirin alone, lifelong, and that's it.
Okay.
Okay? This is regarding Ahmed, who is atrial fibrillation patient with coronary artery disease and has a recent elective PCI, but his age is less than 65 and CHADS score is 0. Is it clear for everyone? Ahmed will take clopidogrel and the aspirin for 1 year, then he will be on aspirin lifelong. Okay. I need a second person. Who would like to volunteer for the next option? I can take them like, who is there? Armia, can you open the mic, please?
Yes, I open it and ready. Okay.
Okay. So in case of Armia, he is like Ahmed, like has atrial fibrillation and has recent elective PCI, but the age of Armia is more 65 or more, like let's say Armia is 70 years old. Okay?
Okay. You want me to answer?
Afib, the addressing. Okay. So Armia is 65 or more. what I'm going to give him, what I need to add in addition to the antiplatelet, because now he is older and he has a higher risk now of developing blood clots.
So now for me, for the age more than 65, new oral anticoagulant, okay? Plus Atrial Fib plus recent MI or PCI or elective PCI, as you said. So I add a clopidogrel.
Okay. Okay, Armia, let's make it simple for everyone. Because Ahmed has a lower risk of blood coagulation, I only give him clopidogrel and aspirin. Okay? Because Armia has a higher risk, I will substitute aspirin with oral anticoagulant. Okay? And the same for 1 year, 12 months. Okay?
Okay.
I will do the same. After 1 year, what did I ask Ahmed to do? To stay on aspirin. After 1 year, I will ask Armia to stay on the oral anticoagulant.
Yes.
Okay, people? Is it clear until when? Until now for everyone?
So he will be on oral anticoagulant for lifelong after 1 year?
Yes.
Yes.
Yeah, doctor, I think there's one missing point that you still need to consider. If he's high risk of thrombosis, you can try like triple therapy. Whereas like oral anticoagulant,
Yes, I think he should start double antiplatelet if he is in PCI, is a recent elective PCI plus myocardial infarction. So we should consider double antiplatelet with the new oral anticoagulant for 6 months. Then
so even
for 6 months double antiplatelet. Then I have to consider new oral anticoagulant with clopidogrel for 6 months, and then new oral anticoagulant lifelong.
Dear respective colleagues, I told you we have 6 options. We only took 2 options until now. We still have 2 options.
I know. My question, you said in the beginning he is elective PCI, and after that you put myocardial infarction only. So which one you talk about now?
Elective PCI.
Yes, sir. You said
with
that elective PCI,
myocardial
and then now you write all recent MI as Noah said.
I didn't write. I'm not the one who is writing that.
Yeah, now it's oral anticoagulant and clopidogrel. It's okay now.
I don't write. It's
Who is writing?
It's chance writing, not me.
Okay, thank you so much.
Okay. Now, Ahmed and Armia represent the patient with atrial fibrillation and recent elective PCI. Okay? Keep that in mind. Ahmed and Armia, the 2 males, represent the atrial fibrillation with recent elective PCI. Okay? Okay. Now I need other 4 volunteers to volunteer. I will take 4 cases together now, or 4 conditions that are related, like Ahmed and Armia, but I need them to be female, please, so we can remember it easier. So I will start with Noha Al-Kholi. Can you open the mic, Noha?
Yeah, sure.
Okay. So now I'm talking about the patient who has atrial fibrillation associated with STEMI or non-STEMI, myocardial infarction. Okay?
Okay.
So If the age is less than 65, I have two options or two cases or two scenarios. And if the age is 65 or more, I have other two options. To make it easier for everyone to remember, I will take Noha and Noha as the example of people under 65 who has atrial fibrillation and STEMI or non-STEMI. I will start with Noha Al-Kholi. So, Noha has atrial fibrillation, okay? And she has non-STEMI, and she didn't have PCI. So Noha Al-Kholi has atrial fibrillation with non-STEMI and not PCI. And of course, her age is less than 65. Okay, Noha?
Yes, so in this case, I am less than 65. I don't have PCI, just a Afib with STEMI. Am I right?
Yes, ma'am.
Okay, so acetyl salicylic acid with ticagrelol or prasugrel or clopidogrel according to the bleeding for 12 months. Then acetyl salicylic acid alone. I hope I am right.
Okay, yes. So
Okay.
it is the same case like Ahmed. She will use aspirin plus ticagrelor or clopidogrel for 1 year. After 1 year, she will be only on aspirin. Prasugrel Noha is preferred if the patient has PCI. If the patient doesn't have PCI, clopidogrel or ticagrelor is preferred. Okay?
Yeah, I remember now. Okay.
Okay. Okay, Shams, as you are writing, like put equal rather than higher than 12 months, just not to make it confusing. Yes. Okay. Now this is Noha Al-Kholi. Noha Kipik, can you open the mic, please?
Yes, hi.
Hi, how are you?
I'm fine, thank you.
So we are still at the case of atrial fibrillation with STEMI or non-STEMI for a patient who is less than 65 years and the SHADS score is 0. Okay?
Yeah.
But the only difference between Noha Al-Kholi and Noha Kipik, I'm sorry, Noha, what's your name? Because I don't prefer to keep saying Noha Kipik.
My name is Noha Nafash.
Okay. So the difference between Noha Al-Kholi and Noha Nafash is that Noha Al-Kholi doesn't have PCI, but Noha Nafash has PCI. Okay? At that case, what Noha Nafash will take? You can contribute with me, Noha, and if there is anything wrong, we can correct it together.
I don't know, oral anticoagulant like warfarin?
No, no. Did we say, yeah, the patient is still less than 65. Don't go directly to the oral anticoagulant.
Okay, so aspirin with ticagrelor?
Yes. Or clopidogrel or prasugrel. We said that prasugrel is preferred to be used in case of PCI.
Okay.
So the only difference between you and the Noha Al-Kholi is that prasugrel can be used in your case.
Okay.
Okay? Plus aspirin. We will use them for 1 year, 12 months. After 12 months, Noha, what will you take?
Aspirin lifelong?
Yes. Okay? Is it clear for everyone until now, or anything is confusing?
So the difference between STEMI and non-STEMI is that in STEMI, in my case, we can add ticagrelol and prasugrel, sorry.
No, the difference in your case because you has PCI.
Yeah,
Regardless, you has STEMI or non-STEMI. Because you has PCI, we have surgical intervention. In that case, prasugrel was proven to be better than clopidogrel and ticagrelor. Okay. Okay. Now we talk 4 options. Ahmed and Armia, Noha and Noha. Now I have the last 2 scenarios, which is a patient who has atrial fibrillation and has a STEMI or non-STEMI, but the age is 65 or more, okay? Which is a higher risk for blood coagulation. I need other 2 volunteers. I will take Radia. Can you open your mic, Radia, if you don't mind? Okay, Rana, can you open your mic, please? Okay, Sarah, can you open your mic, please? Not Sarah Kalu, Sarah alone. Can you open your mic? Hello, people. Yes, thank you, Shams. I wanted to say hello, people. Thank you for writing that. Are you still alive, people there, or hello?
Yes, sir. All of us are still alive.
Okay. Sorry, can't. My internet is good. Not good. No worries, Sarah. Valentina, can you open your mic, please? I'm sure your internet is great.
Hi, I'm here.
Hi. Okay, so Valentina is alive. Thank you.
I am.
Okay, so Valentina, in your scenario, is a patient who has atrial fibrillation with a STEMI or non-STEMI, and the age is over 65 or 65 or more. I know that you are younger than that, and no PCI. Okay?
Okay.
What do you think you should take?
So this is the high risk patient.
Yes.
Okay, so probably we need to give him something like aspirin and in addition to the warfarin.
Like you are saying oral anticoagulant plus aspirin, correct?
Yeah, yes.
Let's agree on something, okay? The antiplatelet, like the clopidogrel, ticagrelor, or prasugrel, is like a cornerstone in treatment. So yes, I'm going to give anticoagulant and I'm going to give antiplatelet, but I will give clopidogrel, not aspirin.
Okay.
Okay. Okay, Valentina, for how long you will take the oral anticoagulant plus clopidogrel?
I'll give for a year and then I would give ASA. If I feel a bit confused.
Okay, so you remember what we have been doing in the other 4 scenarios? We were combining clopidogrel with something else, and after 1 year, we stop clopidogrel and put the patient on the other thing.
Yes.
Correct?
Correct.
So in your case, we will take oral anticoagulant plus clopidogrel for 1 year. Then, as we used to do, stop clopidogrel and stay on oral anticoagulant. Okay?
Okay.
Yeah. Just I need to mention something here, people. Sometimes a doctor will put the patient on oral anticoagulant for 2 or 3 years or lifelong, depending on the situation. And this is in each scenario. So it depends on the circumstances and the other things. So just we say it for now lifelong, but if you see in practice, like the patient stops the doctor stops the clopidogrel for the patient and keep him in oral anticoagulant for 2 or 3 years, this is still acceptable. It depends on the clinician choice. We just say it like after 1 year, we keep him on that or this, just to make it easier for you to remember as lifelong. But you might find in practice that it's not lifelong, okay? The last scenario is
just I have a question in Valentina case. In Valentina case, we can use oral anticoagulant or with acetyl salicylic acid with clopidogrel or TICA. Is it right?
no. We use oral anticoagulant plus clopidogrel. No aspirin. Aspirin was her suggestion. Okay.
Okay.
The last case, I need to take Ziad. Ziad, can you open the mic, please?
Yes, sir. Yes, doctor.
I'm sorry, Ziad, I selected you for this scenario, but this is the worst scenario. Like
No,
a
no
patient
problem.
has atrial fibrillation, has a STEMI or non-STEMI, his age is 65 or more, and has PCI. Okay?
Mhm.
So, of all the scenarios we have mentioned, we have been on dual therapy for 1 year, correct?
Yes, doctor, correct.
In that scenario, Ziad, we will be on triple therapy because it is the worst scenario, because the risk here is very high.
Yes.
So Ziad will be on oral anticoagulant plus clopidogrel plus aspirin, and this is the first time to mention 3 medications together, for 3 to 6 months. Okay?
Okay.
Then after that, what will happen? Ziad will stop the aspirin and stay on oral anticoagulant plus clopidogrel until reaching the 12 months. Like he used the triple therapy for 6 months, I still have other 6 months. I will stop the aspirin and complete the second 6 months on clopidogrel and oral anticoagulant. Okay, Ziad?
Okay. No.
After the year is done, what will you take?
Oral anticoagulant.
Yes, because we have agreed that the one we stop is the antiplatelet, the clopidogrel. So you will be alone on oral anticoagulant. So now if we come to reiterate the scenario, Ahmed and Armia, seriously? Okay. Ahmed and Armia had atrial fibrillation with recent elective PCI. Okay, there was no STEMI, no non-STEMI in case of Ahmed and Armia. In case of Ahmed, he was less than 65 years and his CHADS score was 0. This was the simplest case. Ahmed has taken aspirin and clopidogrel for 1 year, then stopped clopidogrel and stayed on aspirin. Armia, the only difference between him and Ahmed is that his age was higher, was 65 or higher. In that case, I didn't give aspirin, I gave oral anticoagulant plus clopidogrel for 1 year, then I stopped the clopidogrel and he stays on oral anticoagulant. This is the first 2 cases together. The other 4 cases, it was for a patient who has atrial fibrillation, but he has STEMI or non-STEMI. depending on. The first subgroup is the people whose age is less than 65. We have Noha Al-Kholi, who didn't have PCI, which is a low risk. In her case, we give aspirin plus ticagrelor or clopidogrel for 1 year. Then after that, we stopped the ticagrelor or clopidogrel and she stayed on aspirin. The other case is Noha. The other Noha, she is the same. Her age is less than 65 and she has Afib and she has a STEMI or non-STEMI, but she has PCI. And we said that the only difference with the PCI in this case is that it's preferred to take prasugrel. So she still can take aspirin plus ticagrelor or clopidogrel or prasugrel, but the prasugrel is the preferred one in this case, and she will stay on that for 12 months. After 12 months, she will stop them and stay on aspirin. The other group after was the same group of atrial fibrillation with a STEMI or non-STEMI, but the age is 65 or more. Okay, Valentina represents the person who has no PCI, and in her case, she took the oral anticoagulant plus clopidogrel for 1 year, and after 1 year, she stopped that clopidogrel and stayed on oral anticoagulant. The last and most complicated case was Ziad. Ziad has atrial fibrillation with a STEMI or non-STEMI, and his age is 65 or more, and he has PCI. So because it is the most complicated case, he has been on triple therapy, oral anticoagulant plus clopidogrel plus aspirin for 3 to 6 months. After the 6 months, Ziad will stop the aspirin and keep on oral anticoagulant and clopidogrel for another 6 months. By the end of the second 6 months, which is the end of the year, Ziad will stop the clopidogrel and will be only on oral anticoagulant. If we focus on these scenarios, some of them are almost the same. Correct? I need someone who didn't share with me, but he was anyone focusing with me during the last, other than the 6 people who participated with me? Anyone would like to share with me just to remember what we said again? Anyone would like to share with me now?
Yes, okay.
Who is talking?
Armin.
Armia, you are one of the 6. I need someone
okay.
who is not included, just to make sure that the message is delivered to everyone. I want to Wallahi bas driving and in Egypt. You are a hero, Amr. You are driving in Egypt and attend, you are a hero. Okay. So who else? Sarah,
Yeah, for me, I can talk.
you are Shayma?
Yeah, for
Okay, Shayma.
as I know from your notes, you say if atrial fibrillation plus recent elective PCI and the age is 70, for example, is more than 65, we can use oral anticoagulant plus clopidogrel. What's the name? Clopidogrel, yeah, clopidogrel plus acetylsalicylic acid. We stay like 1 year after we change to oral anticoagulant. But for the people like less than 65, they have atrial fibrillation plus non-PCI and non-STMI. We use acetylsalicylic acid plus oral anticoagulant for 12 months, then we change to acetylsalicylic acid alone. And also for the people like less than 65, and
I'm sorry, Shema, for interruption. I think you are mixing some scenarios together. Okay?
Yeah, I just write the notes. For the people that they have atrial fibrillation non-STMI, non-PCI, we use ASA, زائد an OAC. Then for 12 months, then we change to what?
Okay.
I write ASA.
So we have two big groups, okay?
Yeah.
The first group is atrial fibrillation and elective PCI, but they don't have STEMI or non-STEMI. They don't have any problem with STEMI or non-STEMI. This is the first group, which is Armia and Ahmed. This is like the easy group. Just not to get it confused. Yeah, if you get back there, Shams, thank you. You see what Shams wrote? Afibrillation plus elective PCI. There is no STEMI or non-STEMI here in that case. Only Afib and the elective PCI. Are you there, Shaima?
I am with you. Okay.
Because I think you said, or you mixed it something, I got confused. This is why I have to reiterate it. This is how you see it, or this is how you understand it?
Yeah, this is the first case.
Yeah, but just not to confuse, don't to get confused, because you will find in the other group of 4, it's for the people who has AFib, but they have STEMI or non-STEMI. We deal with STEMI and non-STEMI the same way. Okay?
Because actually, Doctor, I not write this case for Ahmed and Armia together. Yeah, can you go down, please? Yeah, I not write this.
Yeah, Shams, you know what you did? Because you didn't write Ahmed. You only wrote Armia, but you didn't write Ahmed case.
Yeah, that's why I just write after Armia, Noha right away.
Yeah, there is a case of Ahmed Shams that is missing, which is the atrial fibrillation with elective PCI, but the age is less than 65. Yeah, in case of Ahmed Shams, we use aspirin plus clopidogrel for 12 months because it is the simplest case. Is there a chance to make Ahmed before Armia? This is how we can go through the age, like the younger first, then the older comes later. This is how we went through all of them. So we can like memorize them better. Please, if you can, thank you. Yeah, in case of Ahmed, age is less than 65, so it's a simple case. At that point, I give aspirin with clopidogrel. For 12 months, then aspirin after 12 months. Okay, now it's clear, Shaima?
Yeah, now it's clear.
Okay, so Shams, can you go down? Go down to the last. We will add something. Is this the last point? Yeah, okay. Can we write that Ahmed is unique? Just write it like that. Ahmed is unique. No one else is like Ahmed.
Thank you, doctor.
My pleasure, sir.
I have a question, doctor. When we say oral anticoagulant here in all of this include warfarin plus the
yes.
plus
I said that in the beginning, plus the new oral anticoagulant. Warfarin or the new oral anticoagulant. Ziad is unique. If you can write
Excuse
down
me,
that.
it's Ziad is unique, yes. Not Ahmed. Sorry, Tantawi.
I'm sorry.
Can I ask you a question, doctor?
Yes.
Yeah, there is a case where patients have Afib, but there is no PCI and no cardio problem yet. In this case, do we need to give him anticoagulant or antiplatelet?
I'm sorry. What's his age?
Okay. Let's say above and under. I mean only Afib. There is no complication. No complication yet.
You remember the algorithm we went through?
Yeah.
What do you think? Do you need to give him?
That's my question.
If the patient is less than 65, we will not give him anything as it's only Afib.
Okay.
I mean, for the blood coagulation.
Yes.
But if he is over 65, we said that we need to give him what?
Aspirin? No.
Oral anticoagulant.
Oral anticoagulant.
Thank you.
Okay.
Shams, why did you remove Ahmed is unique?
Because it was Ziad, not Ahmed.
Yeah, I said Ahmed is unique and I said Ziad is unique too.
Ahmed was the simplest one.
So this is why he is unique.
Was the simplest one.
That's why I'm unique.
Really?
Yeah, just give me a second, Noha, until I finish, then you might know why he is unique and Ziad is unique too. Okay?
Okay.
Also, Shams, if you can write Noha Al-Kholi and Valentina. No, not Noha Al-Kholi, I'm sorry. Armia and Valentina are siblings. Noha Al-Kholi. I'm sorry, Noha Kepek. Would you remind me with your last name again? I'm so sorry.
Nafash.
Nafash. Thank you. Are relatives. Okay, I'm sorry, Shams. Armia and Valentina are siblings, S-I-B, like brother and sister. Or are twins, you can say twins. I'm sorry, can you remove it and put twins to make it easier? Okay, so 1, 2, 3, 4, 5, 6. Okay, so these are the 6 cases. So Ziad, you know why you are unique, correct?
Yes, doctor.
Because of what?
Triple therapy and PCI and we have ACS, PCI, and Afib with the, yeah, I think so, yeah.
Yeah, okay. Armia, what was your treatment?
Yes, sir.
What was the treatment you received?
Oral anticoagulant plus clopidogrel.
And then?
And then oral anticoagulant after 1 year.
And what was your case? What do you have?
My case, it is my age over 65, and I have Afib, but no coronary disease with the recent PCI, recent elective PCI.
Yeah, thank you. Valentina,
Yes, I'm here.
what was your treatment?
So my treatment was clopidogrel and oral anticoagulant for 12 months, and then continue with only oral coagulants.
Yeah, oral anticoagulant, which is the same like Armia, correct?
Correct.
But what was your case?
My case was atrial fibrillation with no PCI and MI.
And what was your age?
Or more than 65.
And this is important.
Yes.
Okay. So, however, you were receiving the same treatment like Armia. Okay.
Okay.
Okay. Noha Kholi.
Yes.
What was your treatment?
My treatment was acetyl salicylic acid plus Tika or clopidogrel for 12 months. Then acetyl salicylic acid lifelong.
Okay, stay online, please. Leave your mic open.
Yeah, sure.
And Noha Nafash.
Yes.
What was your treatment?
For me was STEMI or non-STEMI and age above 65. So we go for oral anticoagulant. Sorry.
Noha.
Yeah.
Noha, what was your age, Noha?
I forget. Under 65?
Yeah.
Yeah, sorry. I was looking for another thing.
Okay.
Yeah, so under 65 is aspirin plus ticagrelol, clopidogrel, or prasugrel because there is a PCI.
Then give me a full answer for 1 year. Then what after 1 year?
Then aspirin.
Yeah. So Noha and Noha were both under 65. They both has atrial fibrillation with a STEMI or non-STEMI, one of them. But Noha Kholi has no PCI, but however, Noha Nafash has PCI. They received the same treatment with an added option for Noha Nafash, a preferred option to use the prasugrel rather than clopidogrel or ticagrelor, which means that both can receive the same treatment, which is aspirin plus clopidogrel or aspirin plus ticagrelor. But the only difference is that Noha can receive aspirin plus prasugrel. So this is why they are somehow relatives, but they are not twins because there is a slight difference.
Okay.
Okay?
Yeah.
So Noha Kholi, you were objecting that Ahmed is unique. You still think that he is not unique?
Yes.
He is or he is not?
He is not. He is simple, not unique.
Okay. Shams, can we change the description of Ahmed to simple rather than unique, please? I'm sorry, Noha.
No worries, it's okay.
Just he is unique because he is the only one we said he will be using aspirin and clopidogrel. We didn't give him a choice. We didn't say that he can take clopidogrel or ticagrelor like in your case. It's
And so
only
that's-
aspirin plus clopidogrel.
So that's the simplicity too.
Okay, I'm sorry, ma'am.
No worries, it's okay.
I cannot win an argument with you for sure.
Yeah.
So people, Ahmed is simple, Ziad is unique. I think Ziad is singular Shams, so you can change R to is. This is because of Noha. She caused a lot of noise and headache today. Yeah. Armia and Valentina are twins. They receive the same treatment. Noha Al-Kholi and Noha Nafash are we are almost done, Noha. Just give me like extra few minutes and the lecture will be done. I'm sorry.
Doctor,
thank you
please.
so much.
Doctor,
yeah.
please. What is the case of Valentina? What is the case of Valentina?
It was AFib with STEMI.
Valentina has a voice and she can talk. We need to keep it memorized for everyone. Valentina,
Sorry,
what were
no.
your case?
So I'm more than 65,
Yes,
AFib plus MI, and no PCI.
thank you.
Okay.
I'm sorry, we need to memorize it by name, by voice. Everyone has his own case and everyone else can remember. Sorry for interrupting you, Noha. Just I wanted her to talk so each person can remember who is Valentina and what was her case. Because you are
It's
already
okay.
with us as you have your specific scenario too, in order not to be mixed with others.
Yeah, I know. Thank you so much.
Okay. And Ahmed just have AFib and no AFib plus recent PCI, but below 65 and no shadow score. Okay. Yes.
Yes.
Yes. Okay.
Okay. So let's say again what has happened here. A patient has atrial fibrillation. Another question.
Yes, but now, what make me confused and understand and thank you. But what me confused? Ahmed have no acute coronary syndrome. Why go to elective PCI?
Maybe he has severe angina and there was no enough supply to the heart. This is why the doctor has to intervene with making PCI to ensure nutrition of the heart.
I had this question yesterday and Dr. Ayman responded to the question. And he said,
Okay.
let's say, yeah.
Because we take the dual therapy, aspirin plus clopidogrel. Aspirin because his age is below than 65 and no shadow score. I agree. It is aspirin, no oral anticoagulant. That's why I understand. Now the clopidogrel because he have elective PCI, but Ahmed has no acute coronary syndrome. No, hello?
He has
Hello?
PCI. Yeah, yes, Armin. He has PCI.
Yes. PCI for any other reason rather than the acute coronary syndrome.
Yeah, he has recent PCI.
Okay.
Okay. So let's say what we started the lecture. We said that for atrial fibrillation patients, we have to put the patient on rate control first using beta blocker or calcium channel blocker. Then we need to consider the rhythm control if the patient has some risk like multiple recurrence or the patient has cardiomyopathy or it's affecting his quality of life. When we talk about the rhythm control, we mentioned many things depending on what is the case, like paroxysmal or persistent. And then we discussed specific cases if the patient has heart failure, what kind of rhythm control we can use. We said if the left ventricular ejection fraction is less than 40, we will use amiodarone. If amiodarone is not effective or the AST level is doubled, we have to make ablation at that point. Then if the patient has left ventricular ejection fraction of more than 40, we can use either amiodarone or sotalol. If the patient has coronary artery disease, we have other options like amiodarone, sotalol, or dorinidarone. If the patient has nothing, no CAD and no heart failure, we can use anything. But if we are going to give the patient propafenone or flecainide, the patient has to be receiving AV blocking agents for rate control like verapamil and diltiazem. Then regarding the anticoagulation therapy, we said that we first look to the age. If the age is 65 or more, we are going to give the patient oral anticoagulant right away. If the patient age is less than 65 and has something of the SHADs like heart failure, hypertension, diabetes, or whatever, we will deal in another way. And we said at the end, if the patient is less than 65 and has nothing and no coronary artery disease, we will not be giving him anything, which is rare to happen, honestly. Then we discussed the 6 different scenarios under our colleague names. If the patient has atrial fibrillation with ACS, if it is the simplest way, it was Ahmed, who has atrial fibrillation with recent elective PCI and his age is less than 65. He took dual therapy of aspirin and clopidogrel for 1 year, then he stopped and stayed on aspirin. For Armia, because his age was over 65, so he need more effective therapy for that. This is why Armia received oral anticoagulant and clopidogrel for 12 months. Then he stopped the clopidogrel and stayed on oral anticoagulant. The other 4 scenarios was for people who has atrial fibrillation with STEMI or non-STEMI. The people under 65 were Nohal Kholi and Noha Nafash. Nohal Kholi has no PCI, so in her case, she used aspirin plus ticagrelor or clopidogrel for 1 year. Then she stopped the ticagrelor or clopidogrel and stayed on aspirin. For Noha Nafash, because she has PCI, we said that in that case, we can use aspirin plus prasugrel. This is the preferable option. However, she can still use clopidogrel or ticagrelor for 1 year. Then she stopped prasugrel or ticagrelor or clopidogrel and stayed on aspirin. The last 2 cases were the people who has atrial fibrillation with STEMI or non-STEMI and their age was 65 or more, which was Valentina and Ziad. Valentina doesn't have PCI, and in her case, she took the same treatment like Armia, oral anticoagulant and clopidogrel for 1 year. Then she stopped the clopidogrel and stayed on oral anticoagulant. Ziad was the most complicated case, and in his case, he has PCI, and he received triple therapy, oral anticoagulant plus clopidogrel plus aspirin for 3 to 6 months. Then he stopped the aspirin and stayed on oral anticoagulant plus clopidogrel for 1 year, for another 6 months. Then he stayed on the oral anticoagulant. So this is regarding the atrial fibrillation. Just the last question I need, or the last point I need to mention here, regarding to deciding the rate control medication. You can use one of 3 things: beta blocker, or calcium channel blocker, or digoxin. But digoxin is not favorable anyway. This is for rate control in atrial fibrillation. Beta blocker, calcium channel blocker, or digoxin. Okay, if the patient has atrial fibrillation and heart failure, the rate control medication is beta blocker, plus or minus digoxin. Like beta blocker alone can control the heart rate, but sometime we might need to add the digoxin. But it's mainly the beta blocker in case of atrial fibrillation patient who has heart failure. I can achieve rate control by beta blocker. Okay, if the patient has atrial fibrillation and the coronary artery disease, in that case, I can use beta blocker or calcium channel blocker, either or, in case of coronary artery disease. Okay, if the patient doesn't have either heart failure or coronary artery disease, I can use any of them: beta blocker, calcium channel blocker, digoxin, or a combination of beta blocker and digoxin, or a combination of beta blocker and digoxin. I'm sorry, if the patient doesn't have heart failure or doesn't have coronary artery disease, I can use either beta blocker or calcium channel blocker, or combination of beta blocker plus digoxin, or calcium channel blocker plus digoxin. Okay, again, the rate control in atrial fibrillation patient, the choice of the agent depends on the other conditions. For the rate control in atrial fibrillation patient, the choice of the medication depends on the other conditions. If the patient has heart failure, I can use beta blocker. So I cannot use calcium channel blocker in case of heart failure. No calcium channel blocker for heart rate in case of heart failure. If it's a coronary artery disease, I can either use the beta blocker or the calcium channel blocker, either or. If the patient doesn't have heart failure or coronary artery disease, I can use either beta blocker or calcium channel blocker, or a combination of beta blocker plus digoxin or calcium channel blocker plus digoxin. The specific information about the medication like apixaban, rivaroxaban, dabigatran, the dose, and blah, blah, we already discussed that in the stroke lecture. So we don't have to go through that again. Yes, Shams, thank you. Yes, exactly. Heart failure, coronary artery disease, none. Yes, exactly. This is what I'm looking for.
Sir, but here, Shams, please, on heart failure, add plus or minus digoxin.
Yes, Shams, please, in heart failure, plus or minus digoxin, but it's not commonly used armia. I just said it because this is how, like, what is written there, but what happens in actual life, it's only beta blocker. But you can add it, please, Shams. In heart failure, you can add beta block. You can use beta blocker plus or minus digoxin. Like if the patient didn't achieve complete control with beta blocker, we can add the digoxin at that case. I'm not sure. Shams, are you still there?
Yes, you don't see the change?
Oh, now I see it. I'm sorry, ma'am. You know
No
that
problem.
I'm sick. Maybe I have a problem. So,
Dr. Ayman, which calcium channel blocker here? It should be non-dihydroxyl or
what do you think, Ahmed? In your opinion, which one I will use in that case? I need something to work on the heart or to work on the blood vessels.
It's hard.
So which calcium channel blockers work on the heart?
Non-dihydropyridine.
Which is?
Non-dihydropyridine.
Which are, what are the
verapamil and diltiazem.
And what was the common side effect of verapamil? What will happen, because it's calcium channel blocker, so it will decrease the motility of the intestine. What will happen?
Constipation.
Thank you, sir.
Thank you.
Yeah. You see, it's simple. Life is simple.
Not to that extent.
Okay. So this is the atrial fibrillation lecture. I'm so sick. I'm so tired. I cannot go further. So I will try to record the insomnia lecture. It's so simple and so short. Now cardiovascular, I think it's done. Tomorrow we will try to finish the endocrinology, hopefully. And after that, we will see what we can do.
سلامتك يا دكتور، ألف سلامة. سلامتك.
Thank you so much. Thank you.
لو مش قادر تدي محاضرات تاني ما براحتك، المهم سلامتك.
براحتك ازاي واحنا نروح فين؟
الراجل تعبان يعني الراجل تعبان.
We're gonna wish a good wish, but stay with us.
اديها لكم انا ما تقلقش.
Okay, we have non-Arabic speaker with us. We need to consider that. I think this is the 18th time to say that. Please, we have non-Arabic speaker, so I'm okay. I will give the lecture tomorrow, inshallah. And yeah, if someone still have any question regarding this lecture or other lectures, feel free to send me the message. I will reply. And I will see you tomorrow. It's not a long time until tomorrow. And I hope this lecture was clear. Okay. Okay. Thank you.
Thank you
Have a
very
good
much.
day. My pleasure. Bye.